ilişkiyle ilgili bir sunum yapmaya çalışacağım.
I'll try to make a presentation between QTc and TDP. What is QTc? What is its relation with other disorders? What is its interaction with antipsychotics? Does it have any effect with polypharmacy? And routine should be asked for ECG because of the QTc. Before introducing you this topic, I would like to say this. With respect to QTc, many people have some ideas, but we don't know which value is normal, which value is not normal, and on a written basis, asking for ECG is problematic. It is the distance between Q to T based on the increase on the heartbeat. That distance may change, therefore corrected TC is used. QT interval prolongation predicts cardiovascular mortality in an apparently healthy population. QTc can increase dorsal point polyventricular tachycardia is known for it as well. I'm not going to mention QTc that much, but it is a very practical information. Before sending our patient to cardiovascular department, we need to see QT as bigger than the half of the 2R distances. So if it is bigger than that value, we can talk about prolongation. QTc is normal between 400 to 420. If it is above 450, it is risky on females. If it is above 470, we can talk about risky QTs. And when QTc is above 500, it is very risky. What is the frequency of it? I'm not going to talk about each and every study, but it is between 1 to 2%. That's all. High severity takes place up to 1 to 2%. Mortality and prolongation is intercorrelated. When QTc is above 500, risk increases up to 1.66%, but it is not a perfect predictor for mortality. What does that mean? Even if QTc is above 500 or 600, there may not be any problems, but when it is less than 500 or 400 or 350, some cardiovascular risks can take place. What are risk factors for QTc prolongation? Heart failure, angina, cardiac myopathies or bradycardia, rhythm disorder, liver and kidney failure. These metabolic disorders as well increase the risk. Ventricular tachycardia associated with administration of thyroxine hydrochloride was the first case report. After that, many other medications were developed. That drug, thyroxine, you all know, it was withdrawn from the market because it increased the QTc interval. When you look at the drugs which were withdrawn from the markets, you can understand that they were withdrawn because they increased the prolongation of that interval. You can see some of the drugs and their effect. A randomized evaluation of 6 antipsychotics agents on QTc is compared in the absence and presence of metabolic inhibition. Haloperidol, thyroxine, ziprasidone, ketapine, olanzapine, risperidone. Ziprasidone producer company made a study. None of these drugs increased the QTc above 500, but you all know it. The thiazotapine increased it and it was withdrawn. Ziprasidone is the second most increasing or inducer for these increasing effects. When you look at the percentage above 60 milliseconds, you can see 30% belongs to thyroxine and 24% belongs to ziprasidone. Ketapine is also a bit higher, but the others are similar to each other. I will try to mention atypical drugs more, but typical drugs increase the QTc intervals if their potency is lower. Fluphenazine, flupentixol is associated with QTc prolongation. Chlorpromazine increases QTc prolongation, and it has TTB risk in the high dosages. Haloperidol is special among type 2. Secondary antipsychotics are special, but haloperidol is even more special because it has very mild interval prolongation when 50 milligram is administered. But IV haloperidol is more important because it is clearly associated with QTc prolongation. It was proven. Based on this, in 2017, IV haloperidol was dealt in one of the FDA articles. It is important in many state hospitals, in the emergency rooms, without the intervention of a psychiatrist. IV haloperidol was given in order to sedate the patient, but it was discontinued in the United States, and we have to do this without psychiatric help. Emergency branch doctors should not give it as IV. What are the other atypical drugs? Amisulpride. For other drugs are compared: amisulpride, olanzapine, sartindol, and clozapine. Sartindol increases QTc interval significantly. Amisulpride increases the intervals considerably as well. Amisulpride's meta-analysis is on the slide. Compared to risperidone and haloperidol, can cause more elongation, and on amisulpride increases the interval up to 60 milliseconds. Clozapine increases dosage with the QTc prolongation. It is correlated from other typical drugs to clozapine. In the past, it used to be said there was no change in the QTc interval, but recent studies suggest that when the clozapine was compared to risperidone and typical antipsychotics, clozapine has been found as a cause for prolongation of the interval. Olanzapine is a very well-known drug to us. From metabolic wise, it's a very risky agent because it increases cholesterol levels and insulin levels. But from the QTc side, we can say that it is much more secure. If you look at the slide, olanzapine among this comparative study is the most secure agent in terms of QTc. It does not have considerable impact on QTc interval prolongation. Olanzapin's QTc effect is very mild compared to others. When you look at other studies, I'll be talking about ariprazole because it is very safe. From olanzapine to ariprazole, there's a decrease on the QTc interval, but it is not different from the others. From olanzapine to risperidone, in that switch, we can see QTc interval has prolonged. When we look at the risperidone, we can see the same study on the slide. Risperidone has mild effect. It is mid-risky. Risperidone been evaluated in many different studies. I'm not going to dwell on the details one by one, but in some of the arms of the trials, considerable prolongation was not detected, but in some of the trial arms, it was found to be risky. When we look at the others, we know that risperidone is less safe than ariprazole. Paliperidone is the metabolite of risperidone. Evaluation of the effect of paliperidone extended release and ketapine on corrected QT intervals can be seen on the slide. There is not a considerable increase of the QTc interval, but in some trials, paliperidone blood levels is associated with QTc intervals. But paliperidone is less risky than risperidone to a certain extent when it comes to QTc prolongation. What about quetiapine? When you look at this slide again, the same slide that I have used before, and it has more increase than other drugs. Some trials suggest that it does not cause any prolongation, but when you evaluate others, quetiapine creates more prolongation than olanzapine and risperidone. Let's have a look at risperidone. It can be the repetition of the previous statement, but it is the highest effect creator among other atypical psychotics. Ziprasidone and QTc was found to be in a relation. There are many data about ziprasidone. In the past, trials were showing the clear correlation between ziprasidone and QT intervals prolongation, but should we give up from prescribing ziprasidone? No. When you look at QTc intervals being above 450, it is 0.8%. It is being above 480, is 0.02%. So it is a very low number actually, and compared to the beginning, there is an increase about 60 milliseconds on the QTc interval. It is 0.7% or 7 per mile. We need to take it into consideration as well. Okay, let's have a look at Sartendol. Sartendol, as you all know, when it comes to the market, it is thought to be a very safe agent, but I mentioned these drugs when they were compared with each other: amulsiprid, olanzapine, Sartendol, and clonazepam. Sartendol is increasing QTs in a very considerable manner. Okay, there are many studies making some comparative trials. Let's have a look at those trials. This is New England Journal of Medicine, Effectiveness of Antipsychotic Drugs in Patients with Chronic Schizophrenia. When we look at this data, none of them has created considerable and significant impact on the QTc interval prolongation, but this is a very old study. This is Lancet's famous trial. 15 antipsychotics were compared in line with their efficacy and tolerability in schizophrenia. When you look at antipsychotics, Sertindol, amisulpride, and ziprasidone create the biggest increase on the QTc interval. So these three are the most risky agents. What are the most secure ones? Ariprazole, poliprazole. Ariprazole is the most secure agent. Dariperidol, ketapine, olanzapine, risperidone, which we prescribe more frequently, are at the mid-risk levels. Maybe this is a very big list, but you can see high risk belongs to triazolidine. It was withdrawn from the market, but IV haloperidol, I would like to emphasize this, ziprasidone and sertridol. These are very risky agents. In terms of medium risk, haloperidol, oral form and IM intramuscular form, risperidone, clozapine, chlorpromazine, fluphenazine. Low risky drugs, olanzapine, ketapine, lurasidone and pulperidone. Ariprazole is the least risky drug. Maybe it has taken your attention compared to ariprazole. We need more data, that's why it is in the second rank. And the polypharmacy. What is the effect of the QTc prolongation? Polypharmacy is not something or extraordinary. It is like a must in the treatment of schizophrenia. If you have a look at this, many of the patients are tried to be treated with clozapine. When it is combined with another material, what happens? In monotherapy, there is placebo. I'm not going to talk about each and every of them one by one, but when there is polypharmacy, on the ziprasidone and sertindol arm, we can see an increase which is considerable, and it is very much in correlation with the risk group that I have shown you as a chart. Antipsychotic dose mediates the association between polypharmacy and corrected QT intervals. Recent meta-analysis and reviews have not shown a net and clear correlation between QTc intervals, but they also suggest that we have to be very careful prescribing these drugs. So on our routine basis, should we ask for ECG from our patients? This is a guideline. Maybe we need to have a look at the guidelines. If the tridazine, midozine or pimozidine is the prescribed agent, before the onset of the treatment, ECG and serum potassium levels must be evaluated. ECG, serum potassium. If you are going to start with ziprasidone, if there are cardiac risk factors, these three must also be asked. Ziprasidone, thiazidine, mesut or pimozidine. Before the onset of these drugs, ECG and potassium serum levels must be evaluated before starting that drug treatment. And ECG follow-up is also required. What about NICE? NICE is a bit different. ECG requirement is limited with these conditions specified in the summary of the product characteristics. A physical examination has identified specific cardiovascular risk, such as diagnosis of high blood pressure. It is important as a difference from APA. The service user is being admitted as an inpatient. It is important. We have to be careful for the inpatients. Written ECG is not a must. It must be personalized. don't have time, but I will make a very short summary. QTc prolongation is a very considerable, significant risk factor for TDP, but it is not the sole risk factor. Among antipsychotics, IV, haloperidol, pimosid, ziprasidone, serindrol, amipriptyl seem to be the most risky agents for QTc prolongation. ECG is not recommended for every routine examination. If there are certain individual risk factors or concomitant diseases, ECG is advised. For the inpatient group, ECG must be asked in order to have a protective and preventive solution for their possible problems.